Let me begin by introducing our distinguished panel. First, to my far right, the physician-in-chief of the Memorial Sloan Kettering Cancer Center is Dr. Jose Baselga. In the center, as we said, beauty in between whatever else the other guys are, Dr. Maura Dickler, who is a medical oncologist, and then to my immediate right is Dr. David Hyman, also a medical oncologist. We'll be discussing one of the most exciting areas of breast cancer research, indeed probably all of cancer research, targeted therapies. We'll tell you exactly what that means in a moment, but let me start with a little quick refresher about breast cancer. This year, more than 230,000 new cases of invasive breast cancer will be diagnosed in this country, and more than 40,000 women will lose their lives to the disease, making breast cancer the second leading cause of cancer death in women after only lung cancer. Now, the good news is that both the incidence and the death rate from breast cancer have been declining, which means there are now close to 3 million breast cancer survivors in this country, and those hopeful statistics are getting much better, due in no small part to what we'll be talking about tonight. The ability to characterize the cancer cell genome and many of its biochemical properties means that now we can decipher rather, what makes a cancer cell different from the other cells in the body. That's also how we know that breast cancer is now at least a dozen different diseases. And more importantly, that also means that we can figure out how to interfere with those genes, enzymes, proteins, receptors, and other key molecules in the cancer cell. Those are the targets that we'll be talking about tonight when we say targeted therapies. By devising therapies to disrupt those targets, we can slow, disable, and perhaps even kill a cancer cell. And because we're aiming at targets that are pretty unique to cancer cells, the treatment should have fewer side effects. And that's where the term precision medicine comes from. But in order to make these exciting new therapies work, you need a sophisticated, caring team of researchers, oncologists, surgeons, nurses, technicians, and caregivers. And that's the Memorial Sloan Kettering model of care. Medical, surgical, radiological, and research teams all working together to ensure that every patient benefits from the very latest and best treatment options. And this is especially evident in Sloan Kettering's clinical trials. Now, before we get to our panel, I want to show you a short clip from The Emperor of All Maladies, a 3-part, 6-hour PBS series by documentary filmmaker Ken Burns. This clip features our MSK, Memorial Sloan Kettering physician-in-chief, Dr. Jose Baselga, talking about his aha moment when he realized what targeted therapies, in this case Herceptin, could do for breast cancer.
So we all have our moment, right? The moment that we see it. And in my case, it came very early in my career. I remember I had this patient of mine that had failed every single therapy and chemotherapy. The disease was just growing. At the same time, I was conducting the first phase 2 clinical trial of Herceptin. So we started therapy with Herceptin. 2 weeks later, the patient came back, the tumor was gone.
This morning, a breakthrough in the fight against breast cancer.
An antibody that attacks cancer cells like a magic bullet.
That was the moment that I realized we can apply a new therapy that is attacking a fundamental mechanism that leads to cancer. If this is working with Herceptin, this is it. These are the new rules. Back in 1989, the median survival time for patients with HER2-positive metastatic breast cancer was less than 6 months. Today, we are curing more than 90% of these patients. So at every time in the history of humankind and in the story of medicine, there's been a moment, where a disease has been solved. And this is what's happening in cancer today. The science is here for the first time. We are sequencing the genomes of our patients' tumors. It cost $10 million a few years ago, and today it's a few $100s. I don't think anybody is grasping how fast all this is occurring. An acceleration of knowledge, an acceleration of cures. You say to yourself, this is happening. It is truly happening.
And as you'll hear tonight, Herceptin is really just the tip of the iceberg when it comes to what we've learned about breast cancer and how to treat it. So let me begin by asking our panelists to give us a brief overview of their particular areas of research and clinical care, and we'll begin with Dr. Baselga.
Over the last 10 years, we have had, for the first time, the opportunity to look at the DNA of breast cancer. Now, breast cancer, like many other tumors, is a disease of the genome. The genes that are in each breast cell go wrong, something happens, a mutation occurs, or a number of alterations happen, and that is responsible for the normal cell turning into a cancer cell. In the last 10 years, we have been able to decipher the landscape of mutations, and we know that in breast cancer there are at least, I'll say, maybe 15, 20 mutations that are targets that we can use. We can develop therapies against these mutations. So our goal and our function here is to make sure that we bring this test to the public, that we routinely sequence every tumor, that we try to identify which mutations may be responsible for that disease, which mutations are driving that particular tumor, and then try to define and identify the right therapies. And that is, in a nutshell, the concept of precision medicine in breast cancer. 2 or 3 years from now, we would like to have a repertoire, say, of 20, 25 therapies. This includes the new ones and the ones we have already now. And we should be able to look at the tumors, identify what's going on, and then treat them.
Dr. Dickler, tell us about your areas.
I am a breast cancer medical oncologist that really takes care of women both with early stage disease, women who've had surgery and need treatment after their surgery, and then I also take care of women with more advanced stages of disease. I do research really in both groups. For women with early stage disease, I have an interest in looking at some of the side effects from those treatments, particularly on sexual function and quality of life. And for patients with metastatic disease, I'm very interested in improving therapies, particularly in estrogen receptor positive breast cancer, something that Dr. Baselga mentioned. And we're going to talk a little bit about breast cancer and that it's really a heterogeneous disease. But there's lots of new treatments out there, both newer anti-estrogen treatments, and then we're also very interested in combining our standard treatments with new targeted therapies that sort of shut down some of the pathways that we think are important with resistance and regrowth of breast cancer.
Dr. Hyman.
So I'm also a medical oncologist. I work very closely with Dr. Baselga and Dr. Dickler. I work in a clinic that's called the Developmental Therapeutics Clinic. And what that is a clinic completely focused on developing new therapies through enrolling patients on clinical trials. The majority of our trials now are looking for patients whose tumors have specific abnormalities that we identify through the type of genetic sequencing or testing of tumors that Dr. Baselga was mentioning. We're picking the patients who participate very carefully based on the types of therapies that those trials are studying. We have been doing a very large number of trials for women with breast cancer because, as Dr. Baselga indicated, we have many drugs now to develop to treat the abnormalities that we're finding in breast cancer. So that's become a huge focus of our program, and I work very closely with Dr. Dickler to make sure that patients have access to these new therapies. So if one of her trials doesn't have an availability for a patient, we find them one of ours, and we collaborate very closely in that way.
Let's take a look at another clip here from the documentary, The Emperor of All Maladies. We're going to look at exactly how Herceptin works and which is the drug that was aimed at the target being the product of what's called the HER2 gene.
In its regular form, the HER2 gene is vital to normal cell division. It creates antenna-like structures called receptors that send and receive signals telling the cell to divide. But in its malignant form, the HER2 oncogene copies itself over and over, and these duplicate genes create a dense forest of receptors.
The cell goes crazy because there are so many receptors that the only thing the cell can do and knows to do is to grow in a totally uncontrolled fashion. It is not dissimilar to having a very powerful car, a Porsche, a Ferrari, that has the gas pedal stuck. That thing is going to continue to go very, very fast until it crashes.
So that's one of the targets that was found back some time ago. But let's talk about what the different subtypes are. So Dr. Baselga, why don't you get us started with, there's estrogen receptor positive, negative, and triple negative. Tell us a little bit about what that means, since we now know a little bit more about what these receptors are.
Sure. So basically we have three big types of breast cancer. Now, I think this is incomplete. We have many more, and we'll talk about that. The first group is the estrogen receptor positive breast tumors. These are the tumors that are sensitive to hormones. They express high levels of the estrogen receptor, and these are the tumors that are treated quite frequently, as Dr. Dickler was mentioning, with hormone therapy. They represent about between 60 and 70% of breast tumors. The exciting thing about ER-positive breast cancer is that we have a number of mutations that are present in this disease that we can target. For example, there is one mutation, and forgive me for the name because it's incredibly complicated. It's called PI3 kinase alpha. This gene is mutant in 36% of this subtype, and we have therapies against this. We also know that cyclin D4 and 6 is activated in this tumor. That's a second mutation. AKT is mutant in about 4 to 6%. ERB2 is also mutant. So that's one subtype, and that's an area that we are incredibly excited because we have the feeling that chemotherapy is not the solution down the line. So that's one group. Then we have the ERB2 HER2 positive group. That's the one that we just heard. That's between 15 and 20%. These are tumors that used to be incredibly aggressive, but now with these therapies, they do much better. These tumors respond. Are we done with HER2 positive disease? Absolutely not. We're going to be done the day that we cure every single patient with this disease, and we are not there yet. So there are also therapies that we are developing. In the case of HER2/neu, what we are doing is that we are combining different therapies. So we have Herceptin is one antibody, pertuzumab is another antibody, TDM1 is another antibody, and we are combining them together, and the results look really, really good. And then they have the third group that is called triple-negative breast cancer. And it's called triple-negative because they are negative for HER2, they don't express HER2, they are negative for ER, and they are negative for progesterone receptor. So for lack of a better word, we call triple-negative breast cancer. Now, that's a group of multiple tumor types. For example, work done here shows that some of these tumors may express a receptor called androgen receptor, and these tumors may respond to therapies against this receptor. But very exciting, I think, and this is something that has occurred in the last few months, no more than that, these tumors have a lot of mutations. These are tumors that have a lot of alterations in DNA. And you may have heard about the new type of immune therapies that are being developed against melanoma and against lung cancer. Well, guess what? The initial studies with immune therapy in triple-negative breast cancer are beginning to show some remarkable responses. So that's the field that we are trying to focus on.
Dr. Dickler, tell me, how do we go about finding or determining these different subtypes? I mean, how do we know what subtype of a tumor, a particular tumor a woman has.
When the tumor is removed, let's say from the breast at time of initial surgery, that tissue is analyzed in a department of pathology, and they confirm that it's breast cancer, and then they do special testing where they use antibodies to determine whether there's expression of these receptors on the surface of the cell. And it's a little bit of an oversimplification, but that's the idea.
What does that allow you to do by being able to sequence the genetics?
So we can sequence over 400 genes, the whole thing, the whole exome, and we can do it with a small piece of tumor, a tumor that can be stored. We are talking about nanograms. And the test takes to do less than 2 weeks, and the real cost of the test is less than $1,000. And this is coming down. So our biggest challenge now is not to do the test. Our biggest challenge is how to interpret the test. What we have here is we have a team of over 40 oncologists that what they do on their spare time is that they annotate the meaning of what we see so that the report is something that your oncologist can understand. That information holds the secret of the tumor. It tells us the personality of the tumor. It tells us what is driving it. And it also points to the weak points of the tumor, is what we like to call the Achilles heel.
Dr. Dickler, what does this imply? This really means that cancer is fundamentally a disease of the genes. I mean, it's really a genetic disease, which doesn't necessarily mean that it's hereditary. Tell me what the implications are of what we're finding here.
Right, well, really, for breast cancer, only about 5 to 10% is hereditary. Probably we're really just uncovering what is causing. Now, for HER2-positive breast cancer, we've known for a while. That was easier. It is genetic in the fact that there are some breast cancers that when they first develop have a mutation. As Dr. Baselga was referring to, there's a gene, the PIK3CA gene, so it's the bad name gene, but that gene is mutated probably very early in the development of breast cancer. And so it's found at the time of initial surgery, and that gene is often found also if the cancer comes back. So we see that that's a mutation from the beginning. We're also recognizing, though, that some gene mutations are acquired. And this was something that we didn't realize for a long time because we were generally looking at tumor tissue from the primary breast cancer. We didn't have a lot of biopsies of metastatic disease that we could look at in the lab. But really now increasingly we do, and we're recognizing that the genetics or the genes in the metastatic sample actually have changed and evolved from the primary breast cancer. So you have some gene mutations that are there throughout. You have others that are acquired and may even develop due to selective effects of some of the therapies that we're using.
So Dr. Hyman, what does that imply for therapy then?
One of the things we just want to be clear about is that when we talk about mutations or mistakes in genes, what we're really referring to are mutations or these mistakes that have occurred after birth. These are not the type of mutations that you pass on to your children. So these are not necessarily inherited risk factors for breast cancer. And actually, what we do in our test is we look at the breast cancer's genes and we look at the normal genes too. And that allows us to determine what occurred differently in that tumor, what makes it different from all the healthy cells, and gives us a much stronger hints about what's the Achilles heel of that breast cancer. We much more commonly now will offer a new biopsy to a woman who's had breast cancer so that we can understand not what their breast cancer was like genetically when it was removed 10 years ago, but what it's like right now so that we can customize the therapy to what the patient has in the clinic today. And what we're even working on doing, which I think is the next step in the next couple of years, is trying to forego that biopsy and even do the testing from a blood test. So we know that when cancer cells grow, some of them die and they shed the DNA goes into the bloodstream, and now we have the ability to actually look in the blood for those mutations so that you can see a day where you don't have to subject somebody to a biopsy to get this information.
By doing these genetic tests, can you then predict what therapy it will be responsive to, the tumor will respond to?
Yeah, sometimes we can, in that we're learning that sometimes women develop mutations in the gene that codes for the estrogen receptor. Now we've been able to understand with just a few changes, maybe even one change in a DNA base pair, the receptor is in a slightly different conformation or position so that it's always a little bit on. It's always activated. And so certain therapies that we use that lower estrogen may not be as effective because you can lower estrogen until it's undetectable, but if the receptor shape is a little bit turned on all the time, that's not going to be as effective. However, we do have treatments that target the receptor more effectively and actually degrade it.
The tumors are the same. They are ER positive, they are receptor positive, but they are totally dependent initially to the presence of estrogen.
They're
estrogen,
addicted to it.
Yeah, they are addicted. Estrogen is the gasoline, the oil that makes the car run. And in this case, the ER is the car that is being fed by the estrogen. So the majority of therapies that we have, they deprive the tumor from the estrogen sources. So then the receptor is being turned off. And that results in clinical benefit, and the tumors stop growing, and sometimes the benefit is for many, many years. And in many cases, in early disease, the tumor never comes back because it has been shut off.
You starve the tumor.
You starve the tumor to death. What we are beginning to identify is that some tumors that come back, these tumors acquire new mutations in the estrogen receptor gene, in the receptor itself, that somehow let the receptor be turned on all the time.
Even without estrogen?
Even without estrogen. So, you can give as much estrogen suppression as you want. That thing is independent. It's saying, you know what? You are not giving me gasoline. I'm switching to solar. and I'm running anyway. Bye-bye, I'll see you. I'm taking off. So now what we say is, forget about estrogen. We are going to destroy the receptor. And actually, it's a pretty cool idea. A dead receptor is dead. So that's what we are doing. So we are now developing, and Maura is leading the studies, some very potent estrogen receptor degraders. This is a very good example on how we are understanding the science and then apply therapies. We're all familiar with the concept that if you have an infection and you treat with the same antibiotic, it's only going to be a matter of time that that infection will be resistant to the antibiotic and it will develop ways to grow. So the tumor is the same. It adapts. Actually, it's the master adaptator. The tumor has one mission, and that mission is to survive, and it will do anything it takes. So in this case, they're very smart. They develop mutations that makes the tumor independent from the estrogen. It's an amazing piece of biology if you think about it.
The treatments that we apply in the beginning may be actually pushing the tumor to evolve some of these other mutations that protect it from the therapy?
Right, so that's a really important concept, and that's so much of the work that we do is you develop a new therapy or you use an existing therapy and you see it working, and what's equally important as identifying how we can predict who responds to what therapy is understanding why people stop responding. Sometimes you give a drug and then you predictably see a certain new mutation or a new resistance mechanism in the cancer, and so it leads us to believe, well, what happens if we give both medicines, the medicine that treats the first mutation and the second mutation at the same time? Maybe it extends the amount of time that the woman responds a little bit, or maybe it extends it dramatically, like we've seen with HIV. One medicine doesn't control the virus for very long, but 3 medicines controls the virus in some cases indefinitely. So that's why the patients that we see, we're constantly looking to see what's changed, resample the tumor.
The technology available here at Sloan Kettering is what makes a lot of this possible?
Yeah, so we have built a new center. The center is called the Krabi Center for Molecular Oncology. We have many sequencers, we have computational biologists, and we are sequencing now, as we speak, 1,000 tumors per month.
Does radiation therapy, which obviously is frequently part of breast cancer treatment, does that fit into this sort of targeted therapy concept?
It's a great question. So we definitely are looking at combinations of radiation therapy and different newer therapies. One example is the idea of combining radiation therapy with immunotherapy. So the idea there is that you kind of irritate the cancer and you bring the immune system into that tumor, and then you give it a boost with an immune therapy, and then it really kind of wakes up the immune system to recognize what's abnormal about that cancer and attack it everywhere. And we've seen that. We have a number of clinical trials looking at that. Other trials where you might burn the breast cancer in an early stage and then give immunotherapy before surgery. So that's something that we're definitely looking at.
So there is synergism between all of these different approaches.
Yeah, there definitely can be.
Interesting. So Dr. Baselga, we'll let the chief have the final word. Where do you see all of this going?
Yeah, so I think we should think in the short term, say 5 years, and then also in the longer term, try to see where all this is going. I think in the short term is we're going to be able to characterize these tumors as we are. We are going to be able to identify for each tumor what pathways and what genes that tumor is dependent upon, and the repertoire of pathways or the repertoire of mechanisms that any cancer has is limited. It's not 10,000, it's not 100. At most, a cancer will have 3 or 4 mechanisms to grow, and we'll be able to then use combination therapies that are going to be rational, they're going to be incredibly efficacious, and will put us in a very different situation in which we will hopefully prolong lives for many, many years of patients with advanced disease. So that's the short term. Long term, say 10 years from now, 15 years from now, the absolute dream would be to develop a concept that we call it breast cancer interception. It's like a military terminology. So imagine that you could identify very early on that something is cooking in the blood, that before you see any mammography, anything happening, you see that there's a small rebellion of cells that are on their way to develop into cancer. You can detect these rebellion guys, and then you can treat them. So you see, oops, I see an ER mutation coming up, and then you treat for 15 days with that therapy, and then you monitor, and then we are okay, we are fine, and then you follow up. So I think we're going to develop, it's going to be close to impossible to prevent cancer, because people say, let's prevent cancer. I don't see how that's possible. We cannot prevent cancer because cancer is us. We cannot prevent us from existing. You can prevent an infection because it's foreign, but we cannot prevent cancer. But what about if we can intercept it when it's beginning to cook? And then, so that would be the dream job and to have, and then that would be the way that I think we could make final inroads into breast cancer.
Thank you for being with us tonight, and remember, this is all very hopeful. It's going to happen. Thank you and good night.